So we'll now move on to our first moderated panel. And again, I want you to hold your questions till that Q&A session at the end. And first, I'd like to introduce Dr. Luke Neff. Dr. Neff is currently Assistant Professor of Pediatric Surgery at Wake Forest University. He's a veteran of the United States Air Force and served in Afghanistan as a combat surgeon. He has an extensive background in developing translational science models to study the physiology of shock resuscitation. In addition, he has focused his efforts in elucidating the causes of health disparities as they relate to common pediatric surgical conditions. For Luke, the issues of pediatric firearm injury have become very personal. While he was deeply affected by the many injured Afghan children that he cared for, he was not prepared for the magnitude of pediatric firearm injury that he encountered upon returning to the United States and starting his pediatric surgical fellowship. This realization led him to focus his efforts on firearm injury and prevention. So let's go ahead and hear from you now that you're up there, and then I'll introduce our second panelist after you complete your remarks. Luke?
I'm sorry, I went too early.
No. Well, you're just fine.
Excellent. Well, it certainly is an honor to be here, and I want to extend my thanks to the National Academies for allowing me to participate in this workshop, as well as the workshop planning cohort. One of the things that's very interesting to me, even as I took on this new faculty position at Wake Forest, where I started my practice, is the unprecedented number of pediatric firearm injuries that we've seen even over the last 18 months. And that was a point that was driven home in a recent meeting that we had amongst our trauma center leadership. And so, really it's about how we as a healthcare system take action in a preventative manner as opposed to reaction. I have no disclosures, but I will say, regardless of our particular vocations, the folks that are assembled here in the room, as well as those that are joining over the internet, we all serve in some way on the front lines of this disease process, and I really appreciate the way that it was framed just a minute ago by Dr. Hartgarten. Obviously very impactful from a biologic system standpoint. I happen to inhabit the world of direct patient care, and so I would like to share the story of a young woman that I had the opportunity to care for, in the hopes that in some way it would personalize some of these macro issues and themes that we'll discuss over the next 2 days of this workshop. A little bit about me, and Dr. Isham had already mentioned this, but I was an Air Force general surgeon for 4 years. Part of that time included a deployment to Afghanistan, where I had the opportunity to take care of lots of children that were injured by violence. And then when I returned, I went on to do a pediatric surgery fellowship in Atlanta, and was really struck, despite both of those experiences and reflecting back on those, about the fact that as a surgeon, my posture was very similar in both of those locations. Really, it was a reactionary posture. And for obvious reasons in Afghanistan, we weren't able to really affect any preventative methods from a healthcare system standpoint, but I almost felt that same sense of powerlessness with respect to the level of pediatric trauma that we were encountering in Atlanta. And obviously, very reactionary, and the core issues surrounding why these things were happening were highly multifaceted. Some of you may recognize this gentleman. This is one of the Surgeon Generals under the Reagan administration, or the Surgeon General, and he is a pediatric surgeon, actually, or was. And Dr. Koop's comment that was specifically around pediatric injury and trauma, and essentially the idea that if disease were killing our children, I'm sorry, I'm not advancing the slides here. If disease were killing our children in the proportion that injuries and firearms were, then people would be outraged and demand that the killer be stopped. And certainly, he was very politically savvy and saw this, and I think that the same holds true even today. We know that pediatric deaths are the number one killer of children, or pediatric trauma rather, and MVAs, motor vehicle accidents, are far and away the most common cause of pediatric death. But viewed from a case fatality rate, certainly firearms are the most lethal, and I think Dr. Hartgarten had driven that point home earlier. The actual reasons why this happens with respect to children is also multifaceted, whether it be accidental shootings and discharges of weapons that children find unattended and unsecured, or self-harm in our teenage and young adult population, as well as intentional violence, and some of the things that make more headlines with respect to the national news. But the challenge is really, where's our opportunity to intervene, and whether it be in the acute inpatient setting or in the outpatient ambulatory setting. And that's really the thing that we have to wrap our arms around. So I'd like to introduce you to a friend of mine that I had the opportunity to take care of, the privilege to take care of, while in my pediatric surgery fellowship in Atlanta. Her name is Jasmine, and she's 16 years old. She gave me permission to tell her story here today. And much of the backstory came through conversations I had with her and her grandmother over the ensuing time that we've known each other. She was a victim of firearm violence even at the age of 6 months. Her family, her two parents, were killed in the room next to where she slept during a home invasion. And she was raised by her grandmother from that point on. She had family members that were involved in gang activity in the Atlanta area. She lives in East Atlanta, in an area that actually has a above average level of crime, and reports that even on a nightly basis, gunshots are heard in her apartment complex. We know that despite her particulars, just as a young African-American female in Atlanta, and this is some of the data we've collected locally, that as a young adolescent and an African-American, she was certainly potentially at higher risk than others. And then individual risk factors, certainly her family history of violence, the zip code that she lives in, her location and where her apartment is, as well as some of the things that are happening in adolescence. She started to engage, at her own admission, in some risk-taking, high-risk behaviors, was forging new friendships with people that potentially were helping her engage in those behaviors. And then there was some mental health issues, and even the idea of the PTSD and being a previous victim of violence and some of the things that were going on. Before her injury, she was actually having flashbacks or dreams about her mother, and that basically charged a lot of mental health issues that she was dealing with. And so really, this snapshot of this young woman, what is the PCP's role in that as she interacts with the healthcare system on an outpatient basis? And that's a really difficult question because it's so multifaceted. And I personally have been thinking about that, where the opportunities to intervene might have been and how to identify her as an at-risk individual. And I'm hoping to learn more about that over the ensuing a couple of days. So, in February of 2018, she and her friends were out and did not have money to take the martyr back home to their neighborhood. One of her friends called an acquaintance and said, "Can you come pick us up?" And this was a gentleman that Jasmine did not know. They all entered the car, and there was probably about 5 or 6 people in the vehicle. The gentleman behind the wheel was actually involved in some type of altercation, potentially gang-related, and unbeknownst to him, everybody in the vehicle was being followed by another car. At a stoplight, that second car pulled up and emptied about 20 rounds into the vehicle. She was the only one that was hit. This is her CT, and we've already seen some very interesting and graphic images of what firearm injury can do. You can appreciate in her right chest a large degree of pulmonary contusion, and then in her left chest a large degree of hemorrhage. You see her vertebral body there. I think that's T7 or 8 that's been cracked, and then the bullet there. On the axial images, you can appreciate the fact that, well, it's not showing up. Yep, the fact that there is a shattering of her vertebral column and a severing of her spinal cord. She actually came to us, was coherent, was hemodynamically stable. We were able to get those images and ultimately took her to the operating room for a laparotomy where we found multiple injuries to her intra-abdominal viscera and repaired those. Here's a picture of multiple gastrotomies that were repaired. And so she spent roughly 3 months in the hospital in an acute inpatient rehab facility recovering from her injuries. And since that time has had multiple trips back into the healthcare system for various issues related to her injuries. And despite the fact that she's recovered, she is paraplegic for the rest of her life because of her injuries. And so essentially we have this young, healthy, kind of fun-loving girl that's been, her life has been permanently altered. I include this picture right here simply to show that not necessarily her in the wheelchair, but what's behind her. And those are the steps that lead up to her second floor apartment, where her grandmother has to essentially either carry her or place her on the steps so she can scoot herself up. And this is her new reality. This is her life. It's pretty sobering. And so really the question comes up, and where were the opportunities to identify her as an at-risk patient? And in talking more with her caregivers and with her, she did go to annual visits with her pediatrician, and actually, as an intake form, firearms were asked about with respect to, are they in the home? Are there any plans to purchase them? Do you feel safe at home? So some of those rote kind of checklist things were being done with a fair degree of fidelity. She did have several interactions with the local children's hospital leading up to this incident for various other issues. And same thing, intake questionnaires where she was being screened for potential firearm injury risk, but it doesn't really translate to action. The healthcare system violence prevention campaigns is something that I was actually curious about, because we participated in that to some degree. And I asked her grandmother about that, and she said, no, in our community there's really nothing like that. And even in the greater Atlanta area, there are occasional health fairs and things like that where attempts to reach out to the community and provide safe storage mechanisms or provide information about gun violence are attempted, but they're not very targeted. They're not systematic, despite being well-intentioned. So this is what what winning looks like for her today. This is a picture that she was so proud to show me. This was her attempt to do a push-up for the first time, which doesn't seem like too big of an issue, but when you consider her range of mobility and what being able to have the upper body strength to do that means for her and her quality of life, it's actually quite an accomplishment. And then the first day that she was standing. And prevention is really hard. It takes a lot of smart people, and the people assembled in this room and that are joining us online to tackle these complex issues. But even seeing now my current practice, really trying to understand what are the specific interventions that we can take back with us to our healthcare systems. That's vitally important and of immediate concern to me. And so I really want to move from this reactionary model as a healthcare provider, as a pediatric surgeon that sees lots of children that have been injured, into more of a preventive stance. And I'm hoping that we can unlock the research that's needed and the advocacy and move forward. And in spite of all the complexity and the seemingly insurmountable task ahead of us, it's my hope that we can draw inspiration from people like Jasmine here and from each other, and continue to foster a sense of urgency in preventing firearm-related injury in our country. Thank you very much for your time.
Thank you very much. And of course, in the early going here, we are very much interested in what the toll that firearm injury and death takes on individuals and communities. And Jeff, I think or Luke rather, I think your presentation has been very, very effective in illustrating some of the issues and pointing the way to some of the issues that we need to begin to address to move beyond that reactive stance that you've described. So thank you very much.